Next up, we have Chris Stauffer, examining the queer community's healing through a clinical trial of Oxytocin-Enhanced group therapy for methamphetamine users. Chris is dual board certified in psychiatry and addiction medicine. He's assistant professor of psychiatry at the University of California at San Francisco and the recipient of a Veterans Affairs Career Development Award. Clinically, he specializes in the treatment of substance use disorders and post-traumatic stress disorder. We're starting, I hear someone say. His research combines social psychopharmacology, such as oxytocin, MDMA, and psilocybin, with psychotherapy as treatments for PTSD and substance use disorders. Relevant project roles include principal investigator of a UCSF-sponsored clinical trial of Oxytocin-Enhanced group therapy for methamphetamine-using men who have sex with men. That's a mouthful. He's a sub-investigator and lead therapist at UCSF site for MAPS-sponsored trials of MDMA-assisted psychotherapy for severe PTSD, and co-investigator and therapist for UCSF's trial of psilocybin-assisted group therapy for demoralization and long-term AIDS survivors. We really need shorter names for these clinical trials. Anyway, welcome Chris up.
So I can't think of a better way to kick off Pride Month than this conference. So I'm going to ride this energy that Kavan and Ariel brought up here, but I'm going to geek it up. So I'm here in my academic costume to tell you about some science. Just a side story because it popped into my head. So I had was facilitating an MDMA session a couple months ago with this straight guy, and he was talking about how starting at puberty he was really ashamed of his body and being short and being nerdy and not being masculine enough. And then he grabbed my face in his hands and he said, "And now I have a role model." So, I think it was the MDMA talking, but. So I was listening to a podcast of John Cameron Mitchell the other day. He's the creator of Hedwig and the Angry Inch, which got me through high school. I wore out that CD. But he was talking about because queer people have to function in two worlds, they have to, be able to function on the more superficial level and then also function underground, that we get the benefit of learning metaphor really early on. And I think a lot of this work that we're doing, as Terrence, his presentation was a beautiful representation of that. A lot of the work we're doing is in metaphors. And I think, we have the luck, I guess it's not lucky, but we get to overcome adversity, and it creates beautiful art and beautiful political movements, which is this conference is such a nice illustration of. But the shadow side is that there are a lot of people that are still struggling in isolation. And there are a lot of people that haven't overcome and are still really suffering. And this unresolved adversity can cause a lot of harm individually and collectively. And so I think we're all familiar with the fact that queer communities suffer from major health disparities, including serious impacts in the realm of mental health. So we have increased risks of suicide attempts, completing suicide, acquiring mood, anxiety, schizophrenia spectrum illnesses, and up to 4 times the risk of developing substance use disorders. Queer communities also experience basically threats to our very safety. We experience increased risks of violence, including intimate partner violence. And although queer people make up 5% of the general youth population, we make up 40% of the homeless youth population. And the majority of queer homeless youth cite family rejection as the main reason for their situation. 44% report having been asked to exchange sex for money, drugs, shelter, food. And 58% of queer homeless youth report having been sexually assaulted while on the streets. And so I paint this grim picture to illustrate an important point. A lot of these things at the current time end up making people ineligible to participate in current clinical trials with MDMA and psilocybin-assisted psychotherapy. And I think a lot of the underground therapists that have been doing this for decades know that despite these FDA, very strict study criteria, people would do really well with these treatments and would benefit greatly from these treatments. On the other hand, some individuals who wouldn't meet these study criteria would it would be too much of a risk, and that includes people who don't have a sense of basic safety, who don't have a home, people who need their ego strength and their well-worn defenses in order to survive, people who are in situations where they're likely to get re-traumatized during the healing process. It would be irresponsible for us to give these treatments to people in those situations. And so the focus of this research that I'm going to talk about here, basically I'm trying to develop treatments that can take disadvantaged people who have been marginalized, and start to rebuild a sense of basic trust and safety, almost as a bridge to thinking about how we can transition them into receiving these more powerful treatments like MDMA and psilocybin. So we've talked a little bit about the minority stress model. I think it nicely illustrates these 3 layers of stigma. So the first layer is prejudice events or incidents of discrimination, and that's anything from implicit bias, from well-meaning people to targeted violence. The second layer is felt stigma, and that's often experienced as concealment of sexual orientation, things like rejection sensitivity, fear of going into certain spaces. And then the third layer is internalized shame, and that's when the stigma gets internalized and it kind of gets pushed into the unconscious and becomes a belief that there's something truly wrong with the self. And this chain of events, from prejudice to felt stigma to internalized shame, I call this the game of shame hot potato. And so shame it's a notoriously difficult emotion to hold consciously. And so as human beings, if you hold it too long, you get burnt, and so you pass it on to someone else. And if there's no one to pass it off to downstream, and passing it back upstream comes with too many risks, we get stuck juggling the hot potato all alone. And that naturally leads to anesthetic coping processes like excessive alcohol and substance use. So in 2017, it was estimated that in San Francisco, men who have sex with men who use meth at a rate 25 times that of the general US population. And so methamphetamine is a long-acting psychostimulant, and stimulants lead to dopamine and norepinephrine being dumped into the reward centers of the brain at greater levels than any natural reward. And that leads to a really high addiction potential. So it doesn't take long for our brains to learn that to avoid these feelings of vulnerability and shame, all we need is meth to make us feel invincible. And for people with no other support system and no other coping mechanisms, it makes logical sense that that would be something that they would want to do. It was a common story for individuals in the study I'm going to tell you about to have started to use meth as a way to connect socially and feel confident in those contexts, and particularly in sexual contexts. However, with more chronic use, the use became more compulsive, and people became increasingly isolated. And so I'd like to take a second and point out that methamphetamine is a Schedule II substance in the DEA scheduling system, along with cocaine and opioids, versus a Schedule I drug like classic psychedelics, MDMA, and cannabis. So Schedule I, as a lot of you I'm sure know, is defined as having a high potential for abuse, a lack of accepted safety even under medical supervision, and no current approved medical uses. And we can only prescribe Schedule I substances in the context of an FDA-approved research protocol. However, Schedule II on, we can prescribe. So yes, I can prescribe straight up meth under the FDA, or under the trade name Disoxin. It's FDA approved for ADHD and weight loss. I won't prescribe this to patients, but I could, and I can't prescribe MDMA and psilocybin-assisted psychotherapy outside of an approved research protocol. And while we're in comparison mode, so I like to think about the different effects that MDMA and psychedelics have on the mind. And we tend to think of psychedelics as consciousness expanding and the benefits coming through ego dissolution. And meth is more consciousness shrinking or narrowing, and at least temporarily, ego inflating. The most effective treatments currently for methamphetamine use disorder are treatments like the Matrix model, and it's depicted here. It has a variety of treatment modalities, including group and family therapy, and it centers around social cognitive rehabilitation. But at this time, there's no FDA-approved medication for the treatment of stimulant use disorder. And a major problem is that stimulant users in general are really, really difficult to retain in treatment and to recruit and retain in research. And so it's hard to develop new treatments when it's difficult to retain people in a project. And roughly a third or more participants are lost to follow-up within just the first few sessions. And on top of this, queer individuals already experience, for multiple different reasons, general healthcare barriers. And so this brings me to why oxytocin may be beneficial as an adjunct to psychotherapy, so specifically in marginalized populations. So first of all, oxytocin is a neuropeptide made in the hypothalamus. It has wide actions in the brain and body, and some of us might be familiar with its role in childbirth, where it causes smooth muscle contraction of the uterus. It also plays a prominent role in breastfeeding and orgasm. So what's the common thread among these three things? Pleasure. I heard attachment and connection. Yeah. So social bonding and attachment. And it turns out our internal oxytocin systems in all mammals is required for social bonding to happen. Oxytocin is also intimately linked to the parasympathetic nervous system, which is responsible for things like slowing the heart rate during periods of rest. And the opposite of that is the fight or flight mode, so the sympathetic nervous system, and that's activated by stimulants like meth. And in fact, if meth is used chronically, it tends to reduce oxytocin receptor density in the brain's reward center and dysregulate oxytocin levels. And so that might help explain some of the anxiety and social withdrawal and difficulty with treatment retention that we see with chronic meth use. So theoretically, supplementing oxytocin may help reverse these symptoms. And oxytocin has been given for the past couple decades in research, given from the outside. It's a large molecule, it's hydrophilic, so it doesn't really cross the blood-brain barrier when it's taken orally, but you can administer it intranasally, and it has behavioral effects, social behavioral effects that last for up to a few hours. And it's important for me to point out a few things here. So first of all, oxytocin is extremely safe. There are very limited adverse effects. It's not a controlled substance. And unlike psychedelics, oxytocin does not alter consciousness. So if you give it to someone in a study, they guess based on chance whether they got oxytocin or placebo. However, it seems to affect unconscious processes related to social behavior. So even if people are making different choices and behaving differently in measurable ways, even if you ask them and they won't say that they feel like they're making different choices. And so from even before when we knew oxytocin's effects on social behavior, people were studying it as a way to reverse addictive behavior in lab animals. And so studies have shown that laboratory animals who are administered oxytocin are less likely to push a little lever to self-administer meth. Oxytocin also prevents the lab animal version of relapse. And these outcomes are stronger in socially housed animals versus animals kept in solo cages. And that suggests to me that oxytocin is somehow facilitating a shift in attention from relationships with the drugs of abuse toward more social relationships. And just over the past few years, there have been a couple pilot studies in humans for various different substances of abuse, alcohol, cocaine, but this is the first trial to look at oxytocin administration specifically in meth-using populations. And a quick note on the association of MDMA and oxytocin. I assume everybody here is familiar with MDMA. It's an amphetamine derivative, so 3,4-methylene dioxy methamphetamine. And as such, some of its activating effects come from the release of dopamine and norepinephrine, just like meth. However, unlike other amphetamines, MDMA acts primarily on serotonin receptors, including subtype of serotonin receptor that leads to a downstream surge of oxytocin release from the hypothalamus. And it's been shown that this secondary increase in oxytocin from MDMA correlates more highly with the social effects of the MDMA than the actual MDMA levels do. So oxytocin seems to be an important mechanism behind MDMA's effects. And in fact, this study, it's behind the other picture, but this was just published in the journal Nature just a couple months ago. They gave MDMA to mice and found that they were able to reopen social reward learning critical periods, and that reopening of these critical periods was dependent on the oxytocinergic effects. And so let's break that down a little bit. So critical developmental periods are times when certain neural circuits are more plastic, and experiences during social reward learning critical periods dictate how our internal oxytocin system is wired. And it determines what our attachment dynamics look like later in life. If any of you were at Burning Man 2015, you probably remember this art piece. So attachment dynamics are largely unconscious, and they dictate how we approach emotional intimacy. And they're stored primarily in procedural memory, so the same as riding a bicycle, and they're very difficult to change even with effort. So I'm going to give you like the 30-second version of attachment theory, but so the development of a secure attachment, it looks something like our caretaker is responsive, but not too intrusive, and later in life we feel comfortable using emotional intimacy to help alleviate stress. And a secure attachment like this is protective against multiple different illnesses, including substance use disorders. On the other hand, if your caretaker is providing your basic needs during these critical periods of development, but is also a source of fear or shame, when emotional intimacy starts to develop in adulthood, it also tends to be associated with fear and shame. Or childhood neglect is linked to also difficulty accepting emotional support when it's needed in adulthood. And in these instances, the natural stress-relieving properties of social support have been layered over with danger signals. So with that, I'll transition into the study design. So I combine two existing interventions in a novel way: motivational interviewing conducted in a group therapy format, and oxytocin. So first of all, what is motivational interviewing? It's a style of therapy that's actually quite close to, if anybody's seen the MAPS, MDMA-assisted psychotherapy manual. It's just a way of interacting with a person in a non-judgmental way. One of the things that it focuses on is resolving ambivalence. And ambivalence is being of two minds about something, which is a difficult thing for our brains to work out on their own without support. And with substance users, ambivalence is typically, on one hand, I want to cut down or stop using this substance, and on the other hand, I need to keep using it for some reason. And when we come at people from a more abstinence-based model, we take on the role of this, and then the person digs their heels in, and it adds a lot of resistance into the system. But we help them identify this ambivalence within themselves and work it out within themselves. And in a group setting, motivational interviewing, we spend a lot of time normalizing that people will be at different stages of change regarding their use, have different definitions of what recovery even is, and have different goals and different ways of achieving those goals. And so we set the precedent pretty early on that the facilitators are there to maintain the structure, to monitor the group for safety, and to help elicit information in an empathic way, but that the group participants are experts in their own story, and they know what they need in order to heal, and that everybody's story and everybody's needs will be different. So a couple quotes that kind of highlight the philosophy of our approach. This one from Gabor Mate: "Addiction is a secondary problem that comes out of a primary problem. So when we put the emphasis on the secondary problem, but don't pay attention to the primary one, then how can we possibly succeed?" And from Johann Hari: "The opposite of addiction is not sobriety, the opposite of addiction is connection." And so here's the basic timeline of the study. So after enrolling, they would have an initial baseline assessment, and then people would get randomized into group therapy cohorts of 4 to 6 individuals, and they would attend together 6 sessions of motivational interviewing group therapy a week apart with 2 co-facilitators. And the study drug, either intranasal oxytocin or intranasal inactive placebo, was administered to participants together in the same group therapy space 30 minutes prior to each therapy session. And each participant received the same study drug as the other members of their cohort, and the same study drug for all 6 sessions. Our participants consisted of adult, male-identified individuals with a history of sexual contact with men. They all had a DSM-5 diagnosis of severe meth use disorder and had to have used meth at least once in the past 30 days. And we recruited from the SF Ains Foundation, which has one of the city's only harm reduction-based substance use treatment programs. And the Stonewall Project and PROP both specialize in men who have sex with men who use stimulants. So I thought it might be interesting to illustrate the group process and some of the results by sharing a sample group of 4 men. So these stories are based on real participants, but specific details have been altered to protect confidentiality. So just to be very clear, these are not their real names. It's not their real portrait. But I did really like this artist's depictions of men who have sex with men. I thought it captured something that felt familiar to these groups. So this is Rico, 27-year-old. Sorry, I can't see this on the screen, so I'm going to have to read this. 27-year-old homeless man with a diagnosis of depression and borderline personality disorder with multiple serious suicide attempts. Leo, 31-year-old HIV-positive trans man with bipolar disorder. Shane, 35-year-old man with schizoaffective disorder and alcohol use disorder. And Joe, 52-year-old HIV-positive bisexual man experiencing intimate partner violence within his current relationship. And then, of course, in addition, they all had meth use disorder. And so we'll come back to this group as we move through the results of this study. So overall, we had 47 participants who attended at least the first therapy session. 24 received oxytocin, 23 received placebo, and there were 5 group therapy cohorts in both of the treatment arms, so 10 groups total. The average participant was about 43 years old. Our youngest was 22, oldest was 64. And when putting together cohorts, we made every effort to ensure that each cohort included at least 2 people of color, and most of the participants were living with HIV. At the time of study participation, the majority of participants were unemployed or on disability. Most of them were raised in a traditional Western religious household, either some denomination of Protestant or Catholic. The average participant reported between 5 and 6 on the 10-point adverse childhood experiences scale, and higher ACE scores are correlated with all sorts of health-related risks. For reference, an ACE score of 6 or more is associated with a 4,600% increase in becoming an IV drug user and a lifespan shortened by 20 years. 36% of our total participants were either homeless or living in a residential treatment facility at the time of study participation. And interestingly, there was a wide span of educational backgrounds. So a couple people had not completed high school, and then we had 6 individuals with graduate or professional degrees, including an MD. Yet the average income was between $11,000 and $37,000 a year. So a common theme among group members in this study was childhood abuse and rejection by families and communities of origin. And many of the people who were not from the Bay Area, from less accepting areas, came to the Bay Area for sanctuary. But just to illustrate some of this, so Rico had an intrusive single mother who committed suicide when he was 14, and he reported being gay bashed multiple times in his small hometown in Arkansas. Leo, sexual abuse from his stepfather. His mother knew and did nothing about it, and ultimately was disowned by his family when he came out as trans. And Shane had parents who suffered with addiction, was taken by CPS at age 10 and put into the foster system. And then Joe suffered physical abuse throughout childhood by his Baptist minister father in Alabama, and was kicked out of the home when it was discovered that he was sexually active at age 16. This is just a chart that depicts the average number of years out of an individual's lifetime that they used a substance 3 or more times a week. So on average, our participants had already spent a quarter of their lives using meth. We included individuals in the study who used other substances, but meth was their primary choice. And these are some typical patterns of use. So smoking multiple times a week in the context of sex, using IV meth daily, trading sex for drugs. A lot of the participants had recently gotten into treatment and snorting meth on a very regimented schedule, same dose every day, same time, and using meth more frequently when in a relationship with a meth user. So let me walk you through some of our hypotheses and the measures we use to test the outcomes. So first of all, oxytocin-enhanced group therapy versus receiving placebo prior to sessions will lead to improvements in meth craving and use. And craving was measured with a self-report questionnaire at each group session, and use was determined by weekly urine samples. Social cohesion, so most basically we just looked at whether or not they came to the group sessions. And we also used a self-report measure at the end of each group called the group questionnaire. Ironically, it was developed at BYU. And being from Utah, I know that Mormons are really good at group cohesion. And stress reactivity. So during each group therapy session, the participants as well as the 2 co-facilitators were equipped with one of these Zephyr bioharnesses, and that collected psychophysiology data, including EKG data. So when it came to self-reported meth craving, there was no significant difference between the oxytocin and placebo treatment arms. And the same with weekly urine samples. So if people started out group 1 with a meth-positive urine, they tended to end group 6 with a meth-positive urine, and vice versa. If they started and they had become recently, stopped using, then their urine stayed negative, with very few exceptions in both of the treatment arms. But looking at some of the social outcomes, so on the y-axis is the overall attendance for each group session. So we start off session 1 with 100% attendance in both groups. And then by session 2, 1 person in the oxytocin group didn't come, but 25% of the people in the placebo group dropped off at session 2. And in the placebo group, between sessions 2 and 6, we had 70% attendance rate, which is typical for stimulant users, and half that in the oxytocin group. Something we found interesting was that the placebo group went back up session 6, and I think this was due to our compensation structure, where we would give them a little bit of cash for coming to each group, and then we would take the same amount of cash and put it in a bonus pot for the end, and they would get it at the end of the 6th session. And so the placebo people knew that. But this finding is really interesting to me. This is one of those like research moments, but there's lots and lots of literature that shows that if people are able to stay in treatment, that they do better. All right, so now considering some of the possible mechanisms behind this increased adherence. So one of the subscales of the group questionnaire is positive bond, and that's questions like, I felt that I could trust the other group members during today's session, and we cooperate and work together as a group. And so I hypothesized that oxytocin would increase positive bond, and it seemed to do that, but not to a statistically significant degree at any of the time points. However, negative relationships, so that's another subscale of the group questionnaire, and sample questions of that are, the other group members did not always understand the way I felt inside, or the group leaders did not seem to care about me. And so starting at session 3, you can see a significant difference between the oxytocin and placebo arms. Of course, we're not exactly sure what is behind this finding, but one guess is that oxytocin may be halting defensive barriers that prevent trust from developing in the group. And so as emotional intimacy began to develop, maybe the placebo people, that was associated with danger, and they began to feel less safe. And one of the things that kind of, I think, surprised me, I'll admit, working with these groups, was that this cycle of stigma, once people came to the Bay Area where they were seeking sanctuary, that the cycle of stigma for this subset of men continued and even worsened once they came here. So again, a lot of them had the commonality of being rejected by families and communities of origin. And Rico continued to feel marginalized in close relationships due to mental illness symptoms and lack of stable housing. Leo felt marginalized by the mainstream queer community by being a trans person of color, and then within the trans community for being a sex worker and an IV drug user. Shane had problems even getting into treatment because he had 2 Axis 1 DSM diagnoses. And Joe had experienced in the past rejection from dating partners for his HIV status and for his bisexuality. And one of the main jobs of any group therapy facilitator, I feel, is to prevent scapegoating, which is a natural human process that happens in groups. It's when all the unconscious anxiety of the group members gets projected onto one individual. And in this group, very early on, Joe revealed that he was bisexual by discussing a sexual interaction he'd had with a woman. And the other men in the group suddenly reported feeling very uncomfortable. Someone said, I thought this was a group for gay men. And Joe, was very, conveying to them that he was a safe person and okay to have around. But no matter how much we discussed the scapegoating process and worked with the whole group to ensure that everybody felt safe, including Joe, Joe ended up dropping out of the group altogether. And so an important lesson I learned from conducting these groups and witnessing really the deep wisdom each of these participants had is that every individual and every subgroup of the larger queer community has been tasked with managing the stigma that's projected onto us by society, whether you're consciously processing that or not. And in order to avoid internalizing that stigma, or if that's already occurred, to muster up enough courage to begin the healing process, we need support. We can't do it alone. And I think one of the messages that came out of this was each of us can ever so slightly expand what we define as our community, including the things that trigger us the most, and that's the healing edge. So that's a unique spot for each of us. For me, it was, I can accept all the groups of the queer rainbow, but I had a hard time with people who were back in Utah and still struggling and maybe trying to live according to the Mormon doctrine and, be out but not act on it. And those people I looked at, with side eye and a little bit of scorn. And I'm working on that, but I feel like that's my healing edge. And so at the healing edge, I feel like you have one foot in shadow and one foot in light, and you can either choose to step out of the darkness or you can choose to shed a little light and witness each other's pain and feel each other's pain and help each other heal and ensure that the most vulnerable of us don't get left behind. So I'm going to go through some of this rather quickly, but this process of witnessing each other's pain happened in these groups, and more so in the oxytocin groups. And we don't have the data yet, but we're working on linguistic and thematic analyses to see if there was more disclosure and more discussion of trauma in the oxytocin versus placebo groups. Earlier on, that tended to manifest as more kind of basic needs, and so like Rico disclosed being homeless and felt a lot of shame around that. But Shane, said, I've been homeless too for the past 6 months. I just got into this treatment facility, and Leo also has a long history of marginalized housing, and had some tips for the other guys. And then as the cohort moved deeper through the process, many of these groups moved into more personal and more shame-filled disclosures. So things like Leo being sexually abused. And somehow in each of these groups when this happened, there was always at least one other person that had similar experiences, and they were able to witness each other and be with each other during that moment. I'm going to kind of go through this quickly. So effects on physiology, not a significant difference. And these are each of the minutes of a 90-minute group therapy session and the heart rate for those. So session 1, there was a little bit of separation, but not significantly. But by session 5, you could see a difference. And kind of like the negative relationships, the oxytocin group tended to stay the same throughout, but it was the people in the placebo arm who started to escalate. And this could mean a lot of different things. We're also looking at measures like heart rate variability, which is a specific measure for parasympathetic control, and that might give us more of an idea of what oxytocin is doing. So there are limitations to the study. Obviously, it was an exploratory study. It was small. We didn't have a big budget. We were limited to 6 therapy sessions, and we didn't have enough money or staff to do long-term follow-up. And then oxytocin has demonstrated different effects based on gender and sexual orientation, and so our results don't generalize beyond men who have sex with men. Here's some future directions. I'm happy to talk more. One of the things that I am really excited about is taking the group therapy model and moving it into more psychedelic treatments. And Brian Anderson's going to talk about some really cool results of a UCSF study, psilocybin-assisted group therapy in long-term AIDS survivors. And we're also in the process of designing a study of MDMA-assisted group therapy for veterans with PTSD, where one of their MDMA sessions will also be in a group setting. And so just to wrap this up, maybe we didn't get to a point where people were changing their meth use, but a common place for these groups to get to, particularly the oxytocin groups, was discovering the benefit of witnessing each other, the benefit of being vulnerable with a community where there was trust, that could help eliminate shame, and that maybe some point in the future, methamphetamine wouldn't be needed as a coping mechanism. And so I chose a couple of salient quotes. Just like with MDMA therapy, a lot of the words that came out of participants' mouths are like poetry. So Shane, I can see how paranoia kept the foster kids safe. I had to sleep with one eye open. No kid should have to defend himself from people who are supposed to be taking care of him. Part of me hates myself so deeply, so no one else can possibly do more harm than I do to myself. I want to say thank you to that part of me. It kept me safe from getting hurt by other people for a long time. And also ask it to step back a little and make some room for self-compassion. And lastly, I've had walls so thick that no one could get through. And at times I've had no walls at all. I think it's time for a wall that keeps me protected, but is low enough that I can see over and decide who to let in the gate.
If anyone wants to come down for questions, state your name and I'll hold the mic. You can come down over here too.
Hi, my name's Alex. What a fantastic bit of research you're doing. Thank you so much for presenting your findings. I have a question for you about where you see this maybe going. So for the people in the room that have run group therapy sessions, not just with meth-using individuals, with other people, dropout's so huge, right? And so my understanding of your findings is that it looks like this particular intervention with oxytocin reduces dropout maybe by half, at least in this particular case. So do you see, and we know from multiple cultures that there are ways when groups get together to form social cohesion, right? Like whether it's drinking kava in certain cultures or using music or drumming or collective hand-holding to like build a sense of social cohesion. We take some of those technologies to help groups work better, to help the patients work together. But I'm wondering if you see oxytocin being like a new intranasal technology, not just for this particular population and set of concerns, but more broadly, because dropout's so difficult across therapy groups.
Mm-hmm. So a lot of research in oxytocin in the last 10 years or so has kind of been approaching it like any other psychopharmaceutical where, we give people oxytocin, take this spray bottle, take this, X number of times a day and see if it helps you with your alcohol use or helps you with your, schizophrenia symptoms. And it's so context dependent. Something I didn't talk about was, the set and setting of increasing your oxytocin levels artificially really dictates how you react to it. And so there's an in-group, out-group effect of oxytocin. So if you're in a safe space and you use intranasal oxytocin, you tend to become more cooperative, more open. But if you're in a more competitive space or a space where you don't feel safe, you get more closed off and actually get more aggressive. So I think giving people oxytocin outside of a controlled social setting is not going to be too helpful. And so MAPS actually inspired this design. I thought, what if we controlled the social setting and took great efforts to make this a safe space, and gave people oxytocin would be end up benefiting. So I think there has to be some sort of oxytocin is the glue, and then you need something to stick it to. So that's one thing. And then, I think using this in conjunction with either group or individual therapy as a way to increase adherence is where I see it going. And then thinking of it also as a bridge, particularly in populations like this that I think can benefit from MDMA-assisted therapy or psilocybin-assisted therapy as a bridge to get them in a more stabilized space to benefit from those treatments without so many of the risks.
Hi, Chris. Thanks for the wonderful talk. I just want to say, first of all, thank you so much and your team for not succumbing to, the trappings of conventional RCTs by recognizing that, substance use does not exist within the vacuum, that, you're recognizing holistically the whole variety of problems that come with substance use, such as, personality disorder, and you're not putting that into your exclusion criteria. So I think that's rare, and I think that's very commendable, and it sets you up for a lot of hard work, and I think that's a great inspiration for the rest of us researchers. I also want to say, at least they didn't get worse, so there's that, right? I have two specific nerdy questions. Was there correspondence with the residential treatment for the folks who were in residential treatment about them being part of this study, about whether there's a specific proactive choice to decline regimented meth use as part of that program, as a way to possibly explain for why you didn't find any significant findings in reduced use? So that's my first question. And my second broader question is, what are you hoping to at least look for or code for in your thematic analyses?
Mm-hmm. So first question, my clinical research coordinator, Scott, flew out here from New York where he's doing grad school. So he could probably answer that more truly, but I know that we were in contact. If people were in residential treatment, we were in contact, and a couple of times that led to people not being eligible. Their treatment facility said, no, you can't be in this weird study where people are spraying things up your nose. That doesn't sound right. And so we, in some ways that worked against us, but in some ways it was helpful if people had a stable space to go to, and we were communicating with the treatment providers there, they could make sure that they were coming to the group and make sure that they were, staying stable throughout the treatment period. And then coding, so we've started to code, and it takes a lot of effort and man hours to transcribe sessions, and then also if you have 6 people in a group and 2 co-facilitators to, separate it into individuals. But we did like a initial sweep where we took the transcripts from this thing called the decisional balance chart, and it's a motivational interviewing tool. We did that in the second session, and so it was more of like a standardized chunk of time. And the first section is what are the positives of meth use? What are the reasons that you use? And people usually start out and they're like, well, like it makes me feel more social, but blah blah blah. And you have to say no buts. Just get all the positives out, all the good things about meth as you see it. And then once they're able to brainstorm all of that, then we move on to what are the negatives of meth use, and then what are the negatives of stopping, what are the positives of stopping. And we found that with the oxytocin versus placebo groups, just the language spoken in the group without it being separated into individuals, when they're talking about the positives of meth was more authentic, more here and now. There's this thing called Luke, I don't know if you're like linguistic analysis tool, and they look at different, it's all proprietary information, so I don't know exactly how they get it, but yeah, more authentic, more like positive emotional tone. And I don't know if that's good or bad. I don't know if people are feeling more comfortable with us, so they're more willing to divulge how they truly feel, or if oxytocin is making them bond more with meth as their attachment figure. I'm not sure exactly what is happening, but I think it's something interesting. And then we're starting to look at measures of language style matching, which is what groups tend to kind of, not the content of what they're saying, but the support words start to match up as groups move through, and so we're seeing if oxytocin affects that. And then we're trying to find a way of just sort of like divulging things if there's a way to measure how much people are divulging personal traumas. Thanks.
All right. Thanks, Chris.
Thank you.
All right, we're going to break for lunch.